So we'll read today general pathology. Okay. General pathology में there is few chapters like cell injury, inflammations, and neoplasia, immunology. These are important chapters. Okay. So we'll start today by cell injury. See, hypoxia is the most common cause of cell injury. Sorry, there is some technical issues. ठीक है. Okay. Hypoxia is the most common cause of cell injury, and there are also other causes like physical and chemical agents. जैसे कि cell injury may be occur due to radiation exposure, pressure, burns, frostbite, etc. And in chemical agents like poisons, many drugs, poisons, and chemicals. These also can result in cell injury. And next is infection. Infections, these also caused by bacteria, virus, fungus, parasites, etc. It may be also from immunological reactions like autoimmune diseases, any autoimmune disease, or if there is any hypersensitivity reactions will come later in immunology chapter. Hypersensitivity reaction type 1, type 2, type 3, type 4. There are 4 types. Okay. And maybe from genetic causes also. Okay. Cell injury can also from genetic causes and nutritional imbalances also. Okay. न्यूरॉन आर द मोस्ट सेंसिटिव सेल्स इन द बॉडी. ये इंपॉर्टेंट है, ठीक है, क्योंकि दे आर मोस्ट कॉमनली डैमेज्ड ड्यू टू ग्लोबल हाइपोक्सिया. ये इंपॉर्टेंट है. न्यूरॉन आर द मोस्ट सेंसिटिव सेल्स इन द बॉडी and it is most commonly damaged due to global hypoxia. It comes in MCQ. Okay, first, hypoxia is the most common cause of cell injury. It is important here. And neurons are the most sensitive cells in the body, and it is most commonly damaged due to global hypoxia. Will come later on in MCQ. These are also included there. Okay, now ischemia is the most common cause of hypoxia. Note it down. Ischemia is most common cause of hypoxia. Okay. And at the cellular level, the protective effect or strategy is to decrease ischemic brain and spinal cord injuries, transient reduction of core temperature in 92 degree Fahrenheit. Okay. That's why if जहाँ पे ब्रेन में सर्कुलेशन, if where there is less circulation in brain or in spinal cord, there is you will find the patient is cooling rapidly. Okay, patient's body temperature is getting cold. That's why ये जो है transient reduction of core body temperature to 90 degree Fahrenheit. नेक्स्ट स्लाइड नहीं आ रहा है. Now effects of cell injury. What are the effects? We will see. First is adaptation, next is reversible cell injury, and third is irreversible cell injury. Adaptation, cell changes its physiological function in response to any injurious stimulus. Like it may be hypertrophy, it may be dysplasia, it may be hyperplasia, it may be metaplasia. So what are adaptations? I'm writing. See, in adaptations, what are there? There are hyperplasia, hypertrophy, dysplasia, or metaplasia. Okay, and reversible and irreversible. Reversible, the cell may be reversed. The injury can be reversed, and in irreversible, it is not. It cannot be reversed. Now coming to next slide. Reversible cell injury. Erase हाँ. The next slide है. Oxygen dependent cell injury. Reversible cell injury, it is oxygen dependent cell injury. Hypoxia, it is the earliest involvement of mitochondria. ये वो कुछ नहीं है, वो नहीं दिख रहा है. तो इधर क्या हो रहा है? If there is ischemia, there is less O2 supply, okay, and less O2 supply के वजह से ischemia leads to O2 supply less हो रहा है, and ये leads to mitochondria को, mitochondria is affected, and it leads to, we know, oxidative phosphorylation, which is happen in mitochondria, and it is, if mitochondria is affected, then oxidative phosphorylation is also affected. So there is less secretion of ATP. ATP generate less हो रहा है. Less ATP is generated. Okay. This leads to sodium potassium ATPase palm activity decrease. Okay. And this leads to influx of water and sodium, and it leads to efflux of potassium. तो सोडियम पोटेशियम एटीपीएच पंप एक्टिविटी, सोडियम पोटेशियम एटीपीएच पंप एक्टिविटी डिक्रीज हो रहा है एंड decreasing and increasing influx of water and sodium and influx of potassium increasing. Okay, so that's why endoplasmic reticular swelling happen and blebs formation and cellular swelling. So these are the phenomena in case of reversible cell injury. In cell membranes, these are the phenomena. Okay. Now in endoplasmic reticulum, ये जो cell membrane, this cell membrane, these are the phenomena. And in endoplasmic reticulum, there is detachment of ribosomes. We all know ribosomes helps in protein synthesis, and if there is detachment of ribosome, it leads to decreased protein synthesis. And that's why there is lipid deposition. Then endoplasmic reticulum, we also have seen what are the happenings in cell. Now in nucleus. Here is as there is oxygen, it is oxygen dependent cell injury. There is hypoxia, so there is anaerobic respiration in cell, and there is that leads to as decrease ATP से anaerobic respiration, uh, anaerobic respiration, and it leads to glycogenolysis, and that's lead to decreased glycogen. Glycogenolysis happened to decreased glycogen. Okay. What I have told, this is written here. Okay. Clear. Now, cellular swelling, what I am told now, cellular swelling, hydropic, cellular swelling, what I am told now, hydropic changes or swelling is the earliest change seen in reversible cell injury. MCQ के लिए MCQ for MCQ, हाँ, पेन ये आ रहा है, पेन नहीं आ रहा है, नहीं, ये लिख नहीं पा रहा है. Right. So, returning in our slide, there is endoplasmic reticular swelling, cellular swelling, loss of microvilli, blebs, myelin figures. So, in MCQ, the question may come like as there are these are the uh, these are the incidents in which are happens in cell membranes. So, except what I say, मतलब except कौन सा नहीं होता है एंडोप्लाज्मिक रेटिकुलर स्वेलिंग सेलुलर स्वेलिंग लॉस ऑफ माइक्रोबिली ब्लेब्स फॉर्मेशन माइलिन फिगर्स व्हिच आर नॉट प्रेजेंट these like this question may be come. Okay, now endoplasmic reticulum. Endoplasmic reticulum which require ATP for protein synthesis, detachment of ribosome, decreased protein synthesis and lipid deposition, what I am just told. In nucleus, there is increased anaerobic respiration, increased glycogenolysis, and decreased pH, resulting in clumping of nuclear chromatin. This is important for MCQ. This is feature of reversible cell injury, clumping of nuclear chromatin. Reversible and irreversible, ये दोनों में क्या क्या नहीं आ रहा है? रिवर्सेबल सेल इंजुरी एंड इरिवर्सिबल सेल इंजुरी एमसीक्यू आता है लाइक इसमें क्या है इसमें क्या है तो दिस क्लम्पिंग ऑफ न्यूक्लियर क्रोमैटिन इज ऑलवेज यू रिमेंबर कि क्लम्पिंग ऑफ न्यूक्लियर क्रोमैटिन इज ऑलवेज इन रिवर्सेबल सेल इंजुरी रिवर्सेबल and cellular swelling, endoplasmic reticular swelling, loss of microvilli and blebs formation, myelin figures. These are the points we found in reversible cell injury. Now irreversible cell injury. In irreversible cell injury, there is inability to reverse mitochondrial dysfunction and development of profound disturbances in the membrane functions characterize irreversibility. And in irreversible cell injury, the important features are damage to cell membrane and it is due to influx of water, loss of phospholipids and protective amino acids, massive influx of calcium. ये important है massive influx of calcium. We didn't see it in reversible cell injury. We have seen it massive influx of calcium. We have seen it irreversible cell injury. Okay, damage to cell membrane, ये influx of water, loss of phospholipids, protective amino acids and leads to massive influx of calcium. Damage to cell membrane results due to continued influx of water, loss of membrane phospholipids and loss of protective amino acids and loss of protective amino acids like glycine amino acid. Next is calcium influx. calcium influx, formation of large flocculent mitochondrial densities. Amorphous densities, it is important. Amorphous densities, it is we found in amorphous densities in calcium influx. There is massive influx of calcium results in the formation of large flocculent mitochondrial densities and activation of enzymes. So this amorphous densities in mitochondria found in irreversible cell injury. ये याद रखना. Irreversible cell injury in mitochondria, there is amorphous density. MCQ comes from here. Now nuclear changes. In nuclear changes, there is microscopic features like pycnosis, karyorrhexis and karyolysis. In pycnosis, there is nuclear condensation. Karyorrhexis, there is fragmentation of nucleus, and karyolysis, there is nuclear dissolution. MCQ can come like this. Which are the ये तीनों ऑप्शन रहेगा, एक नहीं रहेगा. Pycnosis, karyorrhexis, karyolysis. Which is not found in nuclear changes in irreversible cell injury. Pycnosis, karyorrhexis, karyolysis, it happened in irreversible cell injury. Next, these are some one-liners important for MCQ. Neurons undergo irreversible damage within 3 to 4 minutes. Myocardial cells undergo irreversible changes within 20 to 30 minutes. And fibroblast cells are the most resistant to ischemic changes. Now there are few MCQs which came in last few years. Which of the following is the characteristics of irreversible injury on electron microscopy? Anyone can tell what will be the answer? Reply please. Please unmute yourself and reply. Anyone? Anyone? Okay. Amorphous densities in mitochondria. It will be the answer. I have already told in few slides back, I have already told, I have underlined this amorphous densities in mitochondria. So this will be the answer. Okay. Now, all of the following statements are true regarding reversible cell injury except Tell me the answer. All of the following statements are true regarding reversible cell injury except reversible cell injury में नहीं हो रहा है क्या? Except. So what are the points? Diminished ATP generation ये था, it was there in reversible. Formation of blebs, it was also there. Detachment of ribosomes from the endoplasmic reticulum, it was also there. I wrote there. So what is here which is ये वाला formation of amorphous densities in the mitochondrial matrix, that will be the answer, because except reversible cell injury ये it happened in irreversible cell injury. Just see the above MCQ which I just told. Amorphous densities in mitochondria, it is irreversible cell injury. And now it is asking for reversible cell injury. And reversible cell injury, there is decreased ATP formation, there is blebs formation, there is detachment of ribosomes. Next MCQ is most pathognomic sign of irreversible cell injury. Anyone can answer, please? Most pathognomic sign of irreversible cell injury. Irreversible cell injury, irreversible में amorphous densities in mitochondria, which is characteristic of irreversible cell injury. I am repeatedly telling it, amorphous densities in mitochondria, it is characteristics of irreversible cell injury. And the swelling of cell membrane, ribosomes detach, clumping of nuclear chromatin, these all are due to reversible cell injury. Okay. Next, cells most sensitive to hypoxia are cells most sensitive to hypoxia are in first or second slide. I have told this. Cells most sensitive to hypoxia are neurons. Neurons are the most sensitive cells to hypoxia. Now, irreversible injury in cell is what? Deposition of Ca++ in mitochondria, swelling, mitotic figure, ribosomal detachment. What? Irreversible. I am highlighting this point, irreversible. Anyone? Okay. Irreversible injury, cell injury is deposition of Ca++ in mitochondria. Calcium influx, I have already told. Now, first cellular changes in hypoxia. First cellular changes in hypoxia. What? Cellular swelling, decreased oxidative phosphorylation in mitochondria, alteration in cellular membrane permeability, and clumping of nuclear chromatin. Anyone? decrease oxidative phosphorylation in mitochondria. A will be the answer. Now, intracellular calcification begins in which of the following organelles? You can answer this at least. Answer A. Right. Right. Okay. Okay. Good. Next, we'll moving to the topic necrosis. And last year also MCQs uh, came from this topic necrosis. Last time coagulative necrosis. MCQ came from coagulative necrosis. So these are very important. In coagulative necrosis, coagulative, liqueficative or colliquative, caseous, fat and fibrinoid. These are the types of necrosis. Okay. See, coagulative necrosis, this is the most common type. Most common type of necrosis is coagulative necrosis. And there is loss of nucleus with the cellular outline being preserved. Cellular outline being preserved. Okay. And it is associated with ischemia. And most commonly it is seen in heart, kidney, liver, spleen, and in early or dry gangrene, dry, not wet. Okay. And in heart, especially in first week of MI, myocardial infarction, in first week of myocardial infarction in heart, it is found coagulative necrosis. Jenkins degeneration will coming later. Next is liqueficative and colliquative or liqueficative or colliquative. Liqueficative or colliquative necrosis, this is enzymatic destruction of cells and abscess formation. Okay. And it is most commonly found in brain. This is most important. Brain, only brain, this is most commonly found. And others are abscess cavity, wet gangrene. See, dry gangrene we found in digangrene coagulative necrosis. In dry gangrene, there is coagulative necrosis, but in wet gangrene, there is liqueficative necrosis. And colliquative is also another name of liqueficative necrosis. So, in brain, what type of necrosis we found? In brain, what type of necrosis we found? Liqueficative or colliquative necrosis. Okay. Now, coming to caseous necrosis. This is the combination of liqueficative and coagulative necrosis. Okay. Combination, both combination of coagulative and liqueficative. And there is cheese-like appearance of the necrotic material. There is cheese-like appearance. And it is characteristics of TB. Found in mainly TB. Tubercular granulomas. And also there are other diseases like syphilis, हिस्टोप्लाज्मोसिस. ओके. और एक डिजीजेस है कॉक्सीडियोडोमाइकोसिस. Coccidioidomycosis. Okay. Now fat necrosis. Fat necrosis. This is action of lipase on fatty tissues, and there is saponification. Okay. It is found mainly breast, omentum, and pancreas. In acute pancreatitis, it is found fat necrosis or traumatic fatty necrosis in breast. I have already told breast, pancreas, and omentum. Okay, omentum also. Now, fibrinoid necrosis. Fibrinoid necrosis. This is complexes of antibody and antigen are deposited in vessel wall with leakage of fibrinogen. Fibrinogen out of vessels. Okay. Now, it is found in PAN, polyarteritis nodosa. It is one kind of vasculitis. Okay. PAN, small vessel vasculitis, and malignant hypertension and Asop's bodies, rheumatic carditis. In rheumatic carditis, we found Asop's bodies. So these are types of fibrinoid necrosis. This chart is most important for MCQ from cell injury chapter. Okay. So in brain, what type of necrosis we found? Okay. 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 So next, Zenker degeneration. I've said I'm coming later. So this is Zenker degeneration. Zenker degeneration is types of coagulative necrosis. Coagulative necrosis, and it is true necrosis. Coagulative necrosis. Sorry. Mainly affecting skeletal muscles. Most common it acts more commonly. Most commonly it affects skeletal muscles, and less commonly it affects cardiac muscles. Okay. Skeletal muscles is most commonly affected, cardiac muscles is less commonly affected. And mostly it is found during acute infections like typhoid, acute infections. And rectus and diaphragm are the usual muscles affected. Rectus and diaphragm are the usual muscles affected by Jenker's degeneration. Okay. Next, apoptosis. Apoptosis is also called programmed cell death. It can be induced by intrinsic or extrinsic pathways. So there are two pathways, extrinsic or intrinsic. Normally, growth factors bind to their receptors in the cells and prevent the release of cytochrome C. Cytochrome C. This is important. Cytochrome C. Release of cytochrome C and second mitochondrial activators of capsages. This is not so important, but still you remember. Okay, cytochrome C is important. Remember it, cytochrome C. I'm coming later. So withdrawal or absence of growth factors can result in release of these mediators and initiate intrinsic pathway. And this is also called mitochondrial pathway, the intrinsic pathway or mitochondrial pathway. Okay. And cell organelle playing pivotal role is mitochondria. So, if MCQ come, which organelle playing pivotal role in apoptosis, the answer will be mitochondria. Next is intrinsic pathway. Intrinsic pathway, there is cytochrome C stimulates apoptosis activating factor. Apoptosis activating factor 1 and cytochrome C. In left side, I have said I am coming later about cytochrome C. So here, cytochrome C. Cytochrome C is the main things which stimulates at apoptosis activating factor is called APAF1, apoptosis activating factor. So APAF1 is stimulated by cytochrome C, and then there is activation of capsid 9 and effector capsids, which is 3 and 7. So just remember it, capsid 9, 3 and 7. These three capsids are important here. Intrinsic pathway, capsid 9, capsid 3 and 7. Okay. Now coming to the extrinsic pathway. In extrinsic pathway, there is apoptosis. apoptosis से हो रहा है extrinsic and intrinsic. Intrinsic, I have already told, it happens in mitochondria. So it is called also mitochondrial pathway. And what happens? There is release, cytochrome C release from mitochondria to cytoplasm. Cytochrome C release from mitochondria, which leads to binding of anti-apoptotic activating factor 1. Okay, and it leads to activation of capsid 9, which leads to activation of capsid 3 and 7. I am told now in last slide, capsid 3 and 7 and capsid 9, capsid 3 and 7, and that leads to apoptosis. Now in extrinsic pathway, there is, it is activated by binding of Fas ligand. Okay. Fas ligand, which binds to CD95 cell, CD95 cells, and that lead to that lead to activation of capsid stain and leads to apoptosis. Don't remember it so much, just remember it. Apoptosis 1, apoptosis, anti-apoptosis factor 1 binds with cytochrome C and activation of capsid 7, 9 and 3 which leads to apoptosis. And here Fas ligands binds with CD95 cells. Okay, these are important for MCQ. I'm going to slide. See, this CD95 important. CD95 for MCQ can come. CD95 is plays important role in which pathway? Extrinsic or intrinsic pathway? Okay. And DR4, DR5 association. These also important. And capsids 3 and 7 important. Okay. These are enough for for MCQ from extrinsic pathway. Now next is diagnostic features of apoptosis. Okay. These are chromatin condensation, which is most characteristic features of apoptosis. Chromatin condensation, most characteristic feature of apoptosis, and estimation of cytochrome C. I have repeatedly told just now, cytochrome C most important for MCQ. Estimation of cytochrome C and estimation of activated capsids, which are 3, 9 and 7, 3, 7, 9. Okay. Estimation of annexin V, which is marker for apoptosis, annexin V. Okay. And ये जो step ladder pattern, DNA breakdown at specific sites can be detected by step ladder pattern on gel electrophoresis. So, step ladder pattern on gel electrophoresis is diagnostic features of apoptosis. Okay. And mitochondria is the clinical organelle required for apoptosis. So, the points which are very important for apoptosis are chromatin condensation is the most characteristic feature, and mitochondria is the cell organelle required for apoptosis, and gel electrophoresis demonstrate step ladder pattern. Okay, and annexin B is the marker of apoptosis, and CD95 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 is the molecular marker of apoptosis. In which pathway we found the role of CD95? Anyone? Okay. Okay, okay. So moving to the next slide. These are the examples of apoptosis. See, apoptosis may be physiological and maybe it's pathological. Okay. Suppose I am explaining like this. Uh, Suppose a person, uh, so nahin, apoptosis. Suppose apoptosis can be considered as suicide. You consider apoptosis as suicide, whereas necrosis we have just read, na. Necrosis, like you, necrosis you considered as murder. Okay. So in murder, see, murder is always done by someone else. uh, so इसको याद रखो, पैथोलॉजिकल, someone else, not doing by self. Murder is suicide is doing by self, but murder is always done by someone else. So murder is always pathological. So necrosis is always pathological, but suicide can be, can be committed by oneself, or there may be undue pressure. So it may be pathological. So if anyone doing suicide by oneself, it being physiological, and if anyone doing suicide by undue pressure, so that we can call pathological. So suicide, if we consider suicide apoptosis, so apoptosis may be physiological and pathological. मतलब suicide can be committed by oneself, which is physiological, and suicide can be committed by undue pressure, which will be pathological. I am just telling the example. Okay. So apoptosis may be physiological or pathological, but necrosis is always pathological. Okay. In physiological conditions like endometrial cells, in menstruation, there is apoptosis in endometrial cells. That's why in menstruation, the shreddings occur. Okay. And in cell removal during embryogenesis, and virus infected cells and neoplastic cells by cytotoxic T cells. Okay. So physiological conditions, what are the physiological conditions where we found apoptosis is endometrial cells during menstruation and cell removal during embryogenesis and virus infected cells and neoplastic cells by cytotoxic T cells. And pathological conditions where we found in viral hepatitis, we found councilman bodies. Okay, in viral hepatitis, we found councilman bodies. It important. It is important for MCQ. Councilman bodies found where? In viral hepatitis. Okay. And the other examples of pathological apoptosis are gland atrophy following duct obliteration in cystic fibrosis. Okay. And graft versus host disease. Next is regulation of apoptosis. Regulation of apoptosis is primarily by BCL2 family of genes located in chromosome 18. Okay. So what are the anti-apoptotic agents? Apoptosis prevent करता है, it inhibits apoptosis. Okay. Apoptosis regulation is primarily by BCL2 family, which located on chromosome 18, and there are some members like BEAN, BCLXS that stimulate apoptosis, that called pro-apoptotic agents. Pro-apoptotic agents. So these are the factors which increases apoptosis. BAD, BEAN, BEAD, PUMA, NOXA, BCLXS. A for stimulate. Remember, ये A for stimulates. ये ऐसे याद रखो. And BCLXL, L for lower. Okay. Anti-apoptotic agents which decrease the rate of apoptosis are BCL2, BCLXL, and pro-apoptotic which increase apoptosis are these are. Okay. Next is difference. Difference between necrosis and apoptosis. See, I have told necrosis always pathological. Necrosis is always pathological, whereas apoptosis may be physiological or may be pathological. And necrosis, death of many contagious cells, a group of cells. Necrosis happened in group of cells, and in apoptosis, it is always in single cell. In necrosis, there is cell size increased, and in apoptosis, cell size shrunken. It is important for MCQ. Cell size shrunken, single cell. Okay. Plasma membrane disrupted, and in apoptosis, plasma membrane intact. So in necrosis, plasma membrane disrupted, and in apoptosis, it is intact. Necrosis is a passive process and apoptosis is the active process. Okay. Necrosis causes inflammatory reaction, but in apoptosis there is no inflammation. ये important है. In apoptosis there is no inflammatory reaction. MCQ comes from here. Nucleus, there is changes, pycnosis, karyorrhexis, karyolysis. In necrosis, there are nuclear changes like pycnosis, karyorrhexis, karyolysis. But in apoptosis, there is nuclear fragmentation only. Okay. In DNA GL electrophoresis, we found smear pattern for necrosis. Smear pattern for necrosis. But in apoptosis, we found step ladder pattern. I have told in previous MCQ slide, step ladder pattern on gel electrophoresis. It is feature of apoptosis. Okay. Now, these are some one-liners. Glucocorticoids induce apoptosis, whereas sex corticoids inhibit apoptosis. Okay. Glucocorticoids induces apoptosis and sex corticoids inhibits apoptosis. Capses independent programmed cell death is called necroptosis. Capses independent programmed cell death is called necroptosis. See, in necroptosis resembles necrosis morphologically. Okay. just a minute. Just a minute. See, in necroptosis, it resembles necrosis morphologically. Okay, morphologically it resembles necrosis, but mechanistically there is apoptosis. Okay, mechanistically there is apoptosis, but morphologically it resembles like necrosis. And necroptosis is a caspase independent process. Caspase independent process. Caspase independent necroptosis. And glucocorticoids induce करते हैं and sex corticoids inhibits apoptosis. And factors prevent apoptosis of memory cells are NGFs, nerve growth factor. Now next there are few MCQs. Answer please. True about apoptosis are all except. That means which is false regarding apoptosis. Answer please. Anyone? D. dy cell synthesis होता है तो apoptosis में cell synthesis happens in apoptosis except true about apoptosis are all except which is not happened in apoptosis. Yeah, correct. A, inflammation. Here it is written that inflammation is present. Is it is right? Inflammation is present. I have just told in previous slide, inflammation is always absent. I have highlighted the points. Inflammation is always absent. Okay. Preeti, C. No, no, no. C, no. No, C, no. 3C में clamping of chromatin, it is in reversible cell injury. It is not in apoptosis. Okay. Inflammation is present. This will be the answer because inflammation is absent. And here the MCQ is true about apoptosis are all except. Sorry. Except. Okay. So the answer will be inflammation is present because there is no inflammation in apoptosis. Now, two, cytosolic cytochrome C plays an important function in which? Ashwini, right? A, apoptosis. Good. 3. Ladder pattern of DNA electrophoresis in apoptosis is caused by the action of following enzyme. Anyone? No, caspase is not will be the answer. Here the answer will be endonuclease. I have not tell about it. Here the answer will be endonuclease. This is the enzyme. Okay. That's why ladder pattern appearance comes in DNA electrophoresis. Okay. Endonuclease. Okay. And what you are telling caspase, it is responsible for extrinsic and intrinsic pathway of apoptosis. But in ladder pattern of DNA electrophoresis, this is for the action of the endonuclease. Okay. Now CD95 is a marker of okay. Okay, good, good. Okay. Now, which of the following is an anti-apoptotic gene? Anyone? Anyone? Anti-apoptotic gene. No. Why? Why B? Why B? Alisa was right. C. C. B. No, no. B. No. C. It will be C. C. Anti-apoptotic gene. C. I'm showing in previous slide. Anti-apoptotic agents. BCL2, BCL-XL. Okay. Then what will be the answer? C. BCL2. Okay. Next, morphological changes of apoptosis include. Tell, tell me the answer. Morphological changes. I can't see your responses. B. Alicia, C, B, both. Which one? Which one? नहीं आ रहा है. I can't see your responses. Hey, Preeti. Hey, okay, good. Hey, now next. In apoptosis, cytochrome C acts through. In apoptosis, cytochrome C acts through. Anyone? I have highlighted the point during slide showing. A, good, good. Okay. Next. Next, which of the following induces apoptosis in a cell? That also I have highlighted. Anyone? Which of the following induces apoptosis in a cell? D. Good. Okay. Okay. Moving to adaptation. Adaptation in first, I have said what are the changes after the cell injury. There was adaptation, then reversible. So in adaptation, I said I am coming later. So in adaptation, what are the changes? I have already wrote them, and now I am also saying atrophy, hypertrophy, hyperplasia, metaplasia, and dysplasia. Okay. Now next. See, in atrophy, there is reduced size of the organ. In atrophy, there is size reduction. Okay, and tissue resulting from decrease in cell size and number. So there is decrease in cell size and number. Size and number both. Size maybe it can decrease, and in number also it may be decreased. And it is caused by ischemia, aging, malnutrition. I have already told when I was saying the causes of cell injury. These were the points: ischemia, malnutrition. Okay. Now, so these are caused by ischemia, aging, malnutrition, etc. Okay. And also, atrophy may result due to chronic absence of stimulus, which is called diffuse atrophy. Like in polio, in which leg the polio will be affected, the leg will be thinner. There the muscle will be thinner than the other leg. So this is diffuse atrophy. Okay. Next. Next is hypertrophy. Hypertrophy, there is increase in size and function of cells. Okay. So, actually the laptop is lagging, and the slides are automatically changing. Okay. Sorry for that. Okay. In hypertrophy, there is increase in size. There is increase in size and function of cells. So both size and functions, both are affected. Both are affected. Size and functions of cells, both are changes, hypertrophy. Okay. Like examples are puberty, lactating breast, and skeletal muscle fibers in bodybuilders. Okay, gym boys, gym girls, puberty, lactating breast, and skeletal muscle fibers in bodybuilders. So in hypertrophy, there is size and function of cells both are increased. Size is also increased and function is also increasing in hypertrophy. Okay. Now, next is hyperplasia. In hyperplasia, there is increased number of cells. See, there is only number of cells increasing, hyperplasia. In hypertrophy, there was number of cells and the functions both are increasing. Okay, number of cells and functions both are increasing. In hyperplasia, there is increased number of cells. Okay, it results due to increase in growth factors. Example: breast development in puberty, endometrial hyperplasia, and benign hyperplasia of prostate. It is also called BHP. Okay. Breast development in puberty, endometrial hyperplasia, and benign hyperplasia of prostate. Okay. See, breast development in puberty, it is hyperplasia because there is increased number of cells, but in lactating mother, lactating breast, this is hypertrophy because there is functions also increase and size is also increased. So lactating breast, these comes under hypertrophy, and puberty may growing in growing age breast development, this comes in growing age breast development, this comes hyperplasia. Okay. Next is metaplasia. In metaplasia, there is reversible change in which one differentiated cell type like epithelial cell is replaced by another cell type. Okay. It results for reprogramming of stem cells. Those are known to exist in normal tissues. Just remember it. One differentiated cell type is replaced by another cell type. Example is Barrett esophagus. Here, squamous cell epithelium is replaced by intestinal columnar epithelium. That's why it is also called epithelial metaplasia. It is kind of epithelial metaplasia. Why? There is squamous epithelium is replaced by intestinal columnar epithelium in Barrett's esophagus. Okay. So this is metaplasia. And another example is connective tissue metaplasia. This is myostatis ossificans. Okay. Myostatis ossificans. It is bone formation in muscles after trauma. Myositis ossificans. Bone formations in muscles after trauma. So, Barrett's esophagus and myositis ossificans, these are examples of metaplasia. Metaplasia, hyperplasia, hypertrophy, dysplasia, these all are important for MCQ. Okay. Next is dysplasia. Okay. See, metaplasia, there is replacement. Okay. There is a normal cell replaced by another cell, and in dysplasia, there is abnormal multiplication of cells characterized by change in size shape. Right. Abnormal multiplication of cells characterized by change in size, shape, and loss of cellular organization. सेल्यूलर जो ऑर्गेनाइजेशन है वो भी लॉस होता है. ओके, तो इन डिस्प्लासिया देयर इज एबनॉर्मल मल्टीप्लिकेशन ऑफ सेल्स, changes in size, shape, and loss of cellular organization. But basement membrane is intact. So in dysplasia there is intact basement membrane. Okay, and very important, dysplasia can lead to cancer. Okay, very important. Dysplasia can lead to cancer. So in dysplasia, there is abnormal multiplication of cells, changes in size, shape, and loss of cellular organization. Okay, there is intact basement membrane, but remember it, this can lead to CA. This is important. Now there is calcification. Okay, calcification is of two types. One is dystrophic calcification and another is metastatic calcification. Both are very important for MCQ. Okay, both are very important for MCQ. Calcification begins in which organelle? Mitochondria. Okay, calcifications begins in mitochondria except kidney. In kidney, calcification begins in basement membrane. Okay, this is also important. Except calcification begins in mitochondria of all organs except kidney. In kidney, it begins in basement membrane. Okay. Now, dystrophic calcification. Dystrophic, it is seen in dead tissues. Okay, dead tissues. See, D for dystrophic and D for dead. Okay, remember like this. D for dystrophic, D for dead. So seen in dead tissue, and whereas metastatic calcification seen is living tissue. Okay, and in dystrophic calcification there is serum calcium level is normal. Okay, and in metastatic calcification there is elevated serum calcium level. Okay, and dystrophic calcification we see it at the site of necrosis. Where it is necrosis, there is dystrophic calcification. But I have already said metastatic calcification, it is living cell, living tissue. So it's found in organs which lose acid and have alkaline environment inside them. Like most common, it is found in lungs, and another are kidney, stomach, pulmonary vein, systemic artery, etc. So most common in lungs. So metastatic calcification most common in which organ? It is lungs. Okay. Now examples where dystrophic calcification is happening. Okay. There is a pneumonics. A mnemonics you can remember by that: rat, most for PG. Rat most for PG. Okay. Rat. In R, there is rheumatic heart disease. A for arthromatous plaque. T for tubercular lymph node and tumors. ये जो these tumors in tumors, this rat is different. This rat, rheumatic heart disease, arthromatous plaque, and tubercular lymph node rat. And T for tumors. T for tumors is the mnemonic for this is most for PG. Most for PG. Most M for meningioma, mesothelioma, and O for papillary carcinoma of ovary, which is also called serous cyst adenoma. Okay. And S for papillary carcinoma of salivary gland, T for papillary carcinoma of thyroid, and P for prolactinema, and G for glucagonoma. Okay. See, one more thing in dystrophic calcification, Samoma bodies we found Samoma bodies. It is found in meningioma. The tumors in the tumors here, the tumors which are written here, some of what is find we found some of what is in these types of tumors: meningioma, papillary carcinoma of ovary, papillary carcinoma of salivary gland, thyroid, and prolactinema and glucagonoma. Okay. See in MCQ, it may be written papillary carcinoma of salivary Samoma bodies found in papillary carcinoma of salivary gland, prolactinema, glucagonema, and instead of papillary carcinoma of thyroid, there may be written follicular carcinoma of thyroid. Okay, this is the tricks. Okay, so Samoma bodies, papillary carcinoma of thyroid. That you remember. Okay. In metastatic calcification, the examples are wherever we found metastatic calcification in hyperparathyroidism, hyperparathyroidism, renal failure, vitamin D intoxication, sarcoidosis, milk alkali syndrome, multiple myeloma, metastatic tumors to bones. Okay, these are the sites we can see metastatic calcification. Okay. This slide is most important for MCQ. Next is aging. In aging, just you remember, there is telomerase, telomeres. Telomeres are the short repeated sequence of DNA present at the linear end of chromosome. Okay. So if there is telomere shortening, that increase in the size of chromatin with age due to decreased telomere activity. You just remember decreased telomere activity, which is uh, decreased telomere activity which causes aging, but increased telomere activity causes cancer. Okay. Decreased telomere activity which causes aging, but increased telomere activity causes cancer. Just remember this thing. And one thing from this slide is Werner syndrome. If there is DNA helicase enzyme deficiency or defect, okay, DNA helicase enzyme deficiency or defect, if there is there it results in Werner syndrome. Werner syndrome में in Werner syndrome there is premature aging. Okay, premature aging, and there is short stature. Short stature, alopecia, graying of hair, premature graying of hair, premature graying of hair, and old looking face because of defect in DNA helicase enzyme. Remember it. Okay. Because DNA helicase enzyme is needed for DNA replication and repair. As it is hampered, then it results in premature aging, which is called Werner syndrome. Okay. And this is important. Decreased telomere activity, which is associated with aging, which causes aging, and increased telomere activity, which causes cancer. Okay. Now, free radical injury. Free radical injury, there is the cause why free radical injury happens. If there is oxidative stress, radiation exposure, drugs like carbon tetrachloride or paracetamol, and metals, iron or copper like metals. Okay. Now there are few antioxidants. Uh, Examples of few antioxidants: if there is enzymatic and non-enzymatic both. Okay. In enzymatic, there is superoxide dismolase SOD. Okay. Superoxide dismolase, catalase, glutathione peroxidase. Okay. And in non-enzymatic, there is vitamin E, cysteine, glutathione, serum proteins like albumin, ceruloplasmin, and transferrin. You remember catalase. Catalase is most important here, and vitamin E and cysteine and albumin, ceruloplasmin, and transferrin. Okay. Now these are the stains commonly used for free radical injury assessment. Okay. Uh, for carmine stains, carmine glycogen. Okay. So if we want to assess glycogen injury, then carmine stain, and for lipid, Sudan black stains and oil red O, and for amyloid Congo red, for calcium von kosher. See here it is important for hemosiderin. Okay, hemosiderin, pearl stain, both two important here. One is hemosiderin for pearl stain. Okay, and one is to detect lipids, Sudan black or oil red O stain. And trichrome is also important. Here collagen appears blue, and in case of smooth muscles, trichome stains appear red. Okay. Last slide. This is the last slide. Okay. These are the microorganisms detected by these stains. Okay. Gram stain for mostly bacteria. Okay. Cicatar stain for HBS AG. Methenamine silver for Pneumocystis carini. Okay. Indian ink from Cryptococcus. And Ginsa or Leishman stain, it is for Plasmodium. Ginsa stain, only Ginsa stain is for Campylobacter and Leishmania. Okay. And H. pylori for Wardinsteri, Ginsa, silver. These three are false for H. pylori. Okay. See, stain used in electron microscopy is phosphofuncsic acid, and 10% formalin is preservative for used. 10% 10% formalin is the preservative used for histopathological specimens. This question also came in previous 2 to 3 years back. Okay, 10% formalin is the preservative used to preserve histopathological specimens, and 10% neutral buffered formalin is the fixative in light microscopy, and 4% glutaraldehyde is fixative in electron microscopy. So these 3 points is important for MCQ. Okay, this much for today. Anyone having any doubt? Please, anyone having any doubt?